Well, hello and welcome to HealthLine this Tuesday evening. I'm Jennifer Blomquist. I have the privilege of hosting the program, and I'm so glad you joined us. If you're one of our regulars, you know the routine. We are live here in the studio, and that's why we keep our phone number at the bottom of the screen for you throughout the show, because we welcome any questions you may have for our guest tonight. We have a cardiologist, just in time for National Heart Month, so that worked out really well. We welcome any questions you may have. Want to tell you have a few choices as far as how to get your questions answered. So my favorite one is if you just call the phone number 969-2720. It's still toll free. If you're outside of Fort Wayne, just put an 866 in front of there, and we'll get you through to a call screener. They don't just throw you on the air, and you can ask the question live. That's a great way to get your answer, because you can interact with our guest, and maybe he needs to ask you some questions to give you a better answer. So that's one choice. The other option you have is you can still call into the call screener and just give the call screener your question, and I'll ask it for you. So that's another option. And then this is kind of brand new. We've only been doing this maybe a few weeks now, texting, which is great. We've had a lot of people take advantage of that. So the phone number is a little different, though. If you're going to text, it's still the 260 area code, but 969-2730. Go ahead and put your question in, and if you feel comfortable, why don't you give us your name and maybe what town you're from. We do not share your phone number, so that all stays private. I just want to make sure you know that. So that's a great way to get your question in as well. So let's go ahead and meet our guest tonight. Somebody who's new to our program, never done it before, so I told him we go easy on him. So this is Dr. Luke Thompson, and you are a cardiologist.
Yeah, thanks for having me.
Sure.
Yep.
Thank you for coming. We want to focus tonight on cardiac imaging, which I feel like the technology in cardiology, even just in the past 20, 25 years, is so different than what it used to be, the capabilities. So we're going to start talking about that, but if you have something cardiology related, maybe it's not specific to the imaging that we're going to be talking about, feel free to call at any time. Why don't we go ahead and just start with some of the basics? When somebody comes in to see you, what are some basic tests or modalities that you can turn to get maybe some better answers?
Sure. So it kind of all depends on the presentation, right? Are we talking more of a preventative aspect? Okay. Is there a symptomology going on?
Yeah.
Something that we're looking to intervene on? There's multiple different non-invasive tests that you can do across all the imaging spectrum. So ultrasound technology, that's your echocardiogram, typically done across the chest with ultrasound. We call that a transthoracic echo. We can also do those from the esophagus if we're looking for specific valvular pathology, so transesophageal echo. Okay. Other testing involves your traditional stress test, ECG, with and without imaging, and there's multiple different types you can do there. So cardiac MRI, you can add on to that, SPECT imaging, PET imaging, a lot of different nuclear cardiology techniques. And then kind of a growing area of focus has become the coronary artery CTA, which is a specialized CT that looks at the anatomy of the coronary vasculature. It's a great rule-out test. It gives the advantage of disease burden and things like that. All of this as a precursor to should somebody need like a cardiac cath or something like that to follow up. And then there's also incorporations of newer technologies like AI to help assist with that, which happy to talk about.
Yeah, I was going to say, I think everybody is excited, but some people a little concerned, and rightfully so, about AI. Although I would say it seems the most promising in medicine. There are other aspects of it that I think people are a little scared about, cybersecurity and just robots taking over the world, things like that. Yeah. So we can get into the AI aspect of it. But, in terms of the tests, unfortunately, both of my mom's parents had a long history of heart issues. And it was really difficult. I mean, this is back in the 80s and the 90s where you didn't get answers very quickly. And, if you needed a test, you had to be sent to maybe a different facility and now a lot of stuff is even in office, right, in the doctor's, office. So I feel like we can get answers quicker and everything is just obviously probably more sophisticated, I would think.
Yeah, the turnaround has gotten a lot better on a lot of that testing. And then with advances in technology too, our sensitivity to pick up a lot of disease states has improved. So if you take traditional stress testing with ECG, the sensitivity on that varies on patient characteristics, the effort given on stress test, as well as the lab tech, kind of the technique of the lab, the expertise. So, you could see anywhere of a false negative, meaning a test that came back reassuring, but there was actually underlying disease, as high as 30, 50%, depending on the lab. Now with the advent of coronary CTA, that accuracy for rule out has improved dramatically with a negative predictive value, which, what are the odds that if this test comes back reassuring, I don't have the disease, exceeding 99%. So,
see, and I'm thinking people probably, they would go to a cardiologist once they have an issue, but people probably don't think a whole lot about imaging in terms of prevention, and I don't know if that's something that you want to talk about. Most people you hope would go to see their primary care doctor once a year, but I don't know how much of a focus is on the heart, or if there are tests, if you're maybe predisposed, have a family history, maybe, things, maybe some imaging things that you might want to ask your doctor about.
Absolutely. So, when you talk about cardiovascular risk from a prevention standpoint, it comes down to patient characteristics. So we're talking genetic makeup, age is a big factor, lifestyle. And when you look at traditional risk assessment tools, so they're classically referred to the Framingham risk, that's a tool that we use to calculate kind of your risk going over the next 10 years of an unplanned event, an MI, for example. We're kind of seeing that isn't as individualized as we like. That was derived from large populations of patients that we kind of generalize to the population. I feel like it tends to underestimate your own individual risk.
Okay.
So now they're becoming frequently more utilized, and that is the coronary artery calcium score, which is a quick CT scan. There's no contrast dye or advanced techniques involved. It's a quick in and out, and what that looks is for calcification of the coronary artery. So you have three main arteries that sit on top of the heart. Their job is to supply blood to the heart and keep it pumping. One of the markers of disease that we can pick up with a screening test is calcification. And we know the extent of calcification you have can either up classify your risk or down classify your risk based on a lot of technical things, but essentially it helps further individualize your personal risk. So that's one of the imaging modalities that's becoming more popular. Some practitioners are starting to use coronary CTA to kind of help guide disease burden and things on top of that. Now, whether or not to do that in asymptomatic patients is still being debated. If you look at our large guidelines that kind of dictate when certain tests are kind of justified, right now we don't have the evidence to back it up, but it's something that might be coming down the future for more individualized risk.
And do you feel like men and women have an equal risk of having heart issues? I mean, there's always, I think that, I used to see a lot of public service announcements about women ignoring their heart health, that typically it's more men. You think of more men having heart attacks than women, but I guess the point they were putting out to women was, you're at risk of a heart attack too. You may not have you may not experience the symptoms the same as a man. So I don't know, do you feel like women need to maybe pay more attention?
Yeah, and that's a big point that you bring up, that when you look at the traditional risk factors, the traditional symptoms for women with cardiac disease, a lot of it can fall under the radar because they don't present with the typical features of cardiac pain. So it's definitely important to get involved early in the preventative stages before disease progresses.
All right, great advice. I didn't want to forget that we did have somebody text in a question for you, Dr. Thompson.
Sure.
So it was Wesley, and he was asking if is a high heart rate, or is your heart rate high during an asthma attack? Would that be normal?
So the short answer is probably yes. So Heart rate is a response that we normally have physiologically. So when you are under stress or in a relaxed state, your heart rate should reflect that. So that's our fight or flight system kicking in, so our adrenaline. So if you have something else going on, and it could be anything medically, infection, asthma attack for sure, you would expect your heart rate to go up to compensate for that. Now, there are some arrhythmias that kind of go hand in hand with pulmonary disease. You can get atrial tachycardia, atrial fibrillation. So it does depend on the rhythm. The rate itself is kind of hard to make a call. It's certainly something that you could pursue, like non-invasive monitoring. So cardiac monitors, we have wearable devices to see what the rhythm's doing, but usually your heart rate does go up with asthma exacerbations. Yep.
All right. Well, Wesley, thank you for texting in that question. And just want to remind everybody watching, you can do that too. You can be just like Wesley. You can text in your question. Again, that number is 969-2730. And again, a reminder, we don't share your phone number. It stays private. And then you can also call in your question. So it's 969-2720. Again, put an 866 in front of there, and it will be a toll-free call. You can also just relay the question to the call screener, and they can give it to me, and I can ask Dr. Thompson that way. So, of course, you kind of touched on this earlier, artificial intelligence, which is really in its infancy. And I feel like, we've already maybe experienced it to a certain degree in the medical world. We've done numerous programs with all different kind of medical specialties where they're using the robotics to actually perform a surgery. It's not the doctor's hands actually working on the patient. So I don't know if you want to talk about it in terms of maybe how it's going to help in the world of cardiology.
Yeah, absolutely. So it's definitely in the infancy, but it's going to be incorporated eventually. And it's starting to be used pretty routinely now with one of the modalities that we use. So coronary CTA. So that's the specialized CT scan that defines the anatomy of the vascular system that feeds the heart. Okay, so you typically have three major arteries that come off, and we use a contrast dye to go into those arteries, and we time the CT scan with the heartbeat. There's a certain point in the cardiac cycle where the heart is very still, and if you can time up your CT pictures with that area in the cardiac cycle, you can get very good images. Now, where AI comes in is it starts kind of the preliminary read, okay? So it can analyze and give you things like plaque characteristics, plaque volume, and it also is kind of a sensitivity enhancer, okay? So where AI right now kind of falls short is it tends to overcall things, which is kind of what you want from an initial screen though, because you're trying to capture disease and not miss disease with this. Right. So we'll get a preliminary read, and you can match that up with your own individual read. Obviously, you correct any type of technical things that could have caused the AI to make it think that it's seen a blockage when it's not actually there, or it tends not to miss, tends to overcall if it's going to make an error. But it's going to get to the point to where it can read almost as good as the human eye.
And is it giving you information that you have to interpret, maybe with your colleagues, or sometimes is the AI going to give us information that we normally wouldn't be able to come up with on our own?
So the things that it's looking at and that they're trying to elucidate, is what are the plaque characteristics that are high risk, right? Okay. So we know that from looking at older data that the more disease you have, the higher risk of having an event is. Okay, so let's do a hypothetical where you've got two different blockages. You have one that is 70% in one artery, and then you have 20% in a different artery. Right now, it's hard to say, regardless of severity, which one may end up causing the MI. They're looking at things like the technical aspects of that plaque composition to investigate to see, do we know which ones are higher risk for rupture? And when should we intervene sooner? AI is going to help us with that from the CT aspect. That's where I see it being the biggest benefit going forward, because right now it's pretty difficult to discern that with the eye.
All right. No, it'll be fascinating. I mean, there's already so much information out there, but then it's hard to believe that it's like you said, we're just starting to touch the surface of artificial intelligence. So I didn't want to skip another text that we received. So it says women have cardiac, a woman called in and says has a cardiac calcium scored of 1,000. So the doctors say, is that typical for her age? Or is that doctors say it's typical for age, asking for advice about that?
So whether or not you should do additional testing on top of your calcium score.
She's 75, I see.
Yes.
Okay, sorry, I couldn't see that other screen.
So 1,000 is high.
Is it? Okay.
Yeah, when you look across age categories, there's kind of a threshold of risk that escalates once you cross 100, 400, and definitely 1,000. In an asymptomatic patient with a calcium score above 1,000, we know that your risk of a coronary event over the next 10 years is much higher than obviously having no calcium. There are some societies that would recommend following that up with a stress test with imaging. So to look at, is there any kind of ischemia or lack of blood flow that is being affected because of these calcifications, and that can further risk stratify. It's not saying that you need to have an intervention done, but it helps add to your individualized risk. And then what you do with that information is how aggressive you should target things like blood pressure, what you should have for your cholesterol targets, because that's all individualized. When you look at some of the guidelines that, the American guidelines tend to wait for a lot of data, which is, they have the reasons for it, before they make aggressive recommendations. So the cholesterol guidelines tend to lag probably a little bit behind, but we should be individualizing cholesterol targets based on individual risk. And with a calcium score above 1,000, I would be pretty aggressive about getting the LDL down and looking at other things like advanced lipid profiles.
I mean, it sounds like, it's like when we do shows with the orthopedic surgeons, they always talk about taking really simple steps, I think some people are concerned they're just going to be thrown on the operating table right away, but, being very conservative. And I assume that's kind of how it is in cardiology, and one thing builds on another. So if you're having one test, chances of needing more in the future, or even more at that time to get a better answer, is that typical of needing multiple tests? In theory, the CTA, if you look at our guidelines, the way the studies were kind of constructed, we have some large trials. One of them is the ischemia trial that looked at what do you do with these stable patients that don't have symptoms and they have coronary disease? How do we manage it? The data shows that you should be able to manage them with aggressive risk factor modification. Now, in kind of America's practice, if you look at it, it probably leads to some layering of testing, but I think that's going to start changing as more data comes out, especially with some of the CT scans. If they tend to overcall lesions, that can sometimes lead to layered testing followed up by cath, but that's something we're sorting out. All right. I just want to remind everybody we do have a few minutes left in the show, but that's plenty of time to get some more questions in. So again, you have the option of texting it. You can call it in. You can talk to the call screener and just relay the question to them. That's why the phone numbers are at the bottom of the screen. So please take advantage. We don't often get a cardiologist on our program, so we only have them for a short time. So feel free to give us a call at any time as we continue our discussion. Do you feel like there's a lot of research being done and more on the preventative side with cardiology? Because I feel like so many people will say, I meet people all the time that say, gosh, my dad died of a heart attack when he was 47, and they feel like they're going to be doomed, to have that same fate. And so I don't know if you want to talk about that, like more of if there's a lot of research going on the preventative side, especially if you have a family history of it, or is it all more lifestyle and environmental? Just because maybe somebody in your family had an episode It doesn't necessarily mean that you're predisposed.
It's super individualized.
Is it?
So there's a lot of factors at play. Genetics is a huge component, believe it or not. For example, we always wonder how much of your cholesterol you can control with lifestyle modifications. They've looked at that. They've looked at 22 different diets in one of the larger studies where they looked at everything from keto to Atkins to Mediterranean and DASH diets. Across all those diets, about 5 to 15% LDL reduction. So you can do the math on that. So the remainder of that is all genetic. So it's important based on your family history and based on other risk factors like diabetes, tobacco use. Those things all enhance your risk of disease. And it's very important to get on top of it early. I think that's key, because there are a lot of preventable things that we can dial in from a cardiac standpoint that if you look at our numbers across the country, maybe we're missing out on a lot of opportunities like blood pressure control and cholesterol control.
Yeah. All right. I want to turn to the screen because we did get another text message. People really like texting, so I'm glad to see that. Let's see. This was, what is the difference between heart pain and digestive issues?
So this is a tricky one. So the nerves in the chest aren't as specific as the peripheral nervous system. So if you pinch yourself on the back of the hand, you know where you got pinched.
Sure.
Sometimes you can have referred pain.
I'm familiar with
all
that.
Those organs in there, it's difficult to tease out.
Because the nerves are so intertwined, is that the
So
reason?
for example, sometimes very bad reflux can present similar to a heart attack, right? But that's why, it's key to dial in on the specifics, the pretest probability, meaning, what's your genetic history, what's your other risk factors, diabetes, smoking, hypertension, and you kind of have to set a gauge for what the pretest probability is. By kind of like a big overview, typically cardiac pain is a pressure-like retrosternal, meaning behind the chest wall, that is made worse with things like stress, exertion relieved with rest. But there's a big spectrum, and especially like we were talking about earlier, women, patients with diabetes on insulin, they don't have those typical features. Okay. But it's pretty hard to tease out sometimes, and that's where additional testing like stress testing or coronary CTA may sometimes add some benefit to that.
Yeah, I guess I do hear the one commonality I've had, other cardiologists refer to or say that a patient will say it feels like an elephant is stepping on their chest. At least that's what men say. Yeah. I've heard women say it's more in the arm.
Arm pain,
instead
nausea.
Yes.
Yeah, sometimes diaphoresis. I've seen it where patients just have weakness. So there's a lot of different things. So that's why it's important if you're concerned that something's going on to seek some medical care.
I was going to say, I worked with a man years ago that he actually had, after the fact, realized that he had a heart attack at work and didn't know it. You always think somebody's going to collapse. He just felt really sick. But then it ended up being months of recovery after that. But, we were just floored because, he was at work doing his normal thing and kept working. But it wasn't until he went home and then just felt so sick that, after the fact found out. So it's not, like you said, there's no cookie cutter, form for everybody. So we only have a minute or two left, so I was just going to ask you a couple things related to National Heart Month, which is February, of course. So years ago, I remember a cardiologist referring to the heart as a sympathetic muscle. Like it really, there's something about, he said, you can feel like you have a broken heart if you're going through something stress or something traumatic. And I don't know if you want to talk about that, like you can present symptoms based on just an experience, not something physical, but emotional. Yeah,
so there is a rare disease, stress cardiomyopathy, where the heart muscle can become very weak, can present exactly like a heart attack. Not exactly sure what causes it. We know it has to do with kind of some misregulation of adrenaline. There are some patient features. Typically, it can be associated with women, but it's important to get checked out if you think something's going on. So we do see it quite often.
I mean, you know your body better than anybody, so
Yep.
if something doesn't seem quite right, you should definitely get some help. So unfortunately, our time is up. Dr. Thompson, thank you so much for coming in tonight. Really appreciate it. So,
Oh, thank you for having me.
thank you. And many thanks to everybody who texted in questions. Really appreciate that as well. So we are done for here tonight, but we will have another HealthLine coming up next Tuesday. So take care, have a great evening, and happy St. Valentine's Day to everybody. Good night.
PBS Fort Wayne was made possible in part by
You gotta find your people,
Good morning.
the ones that make you feel whole.
How you feeling?
You look so pretty today.
Bring it together, you got nothing to lose.
Good job.
In a world full of strangers, you don't know who to trust. You can't go it alone. Everybody needs help.
Go.
You gotta find your people, then you'll find yourself.